Pivotal response treatment, or PRT, is a play-based therapy approach that uses applied behavior analysis techniques in a developmental perspective to target the primary impairments found in individuals with autism. PRT is a comprehensive service delivery model that holds family involvement at the center of treatment. By teaching all of the key people involved within the child's life, the child's family members become the primary interventionists. Due to the fact that PRT is provided across all contexts of the child's environment, it naturally targets generalization. PRT strategies have been utilized to target the development of first words, social skills, and to assist more verbal communicators in developing more refined language and social skills. PRT targets broad areas of functioning, also known as pivotal areas. The 4 primary components of treatment are focused on motivation, responsivity to multiple cues, self-initiations, and self-management. To date, there are no standardized measures available to determine the appropriateness of PRT to specific individuals or populations. However, it has been proven effective for children, adolescents, and adults with ASD, as well as with individuals with language and cognitive impairments. In order to assess these individuals, developmental adaptive behavior and language assessments were utilized to create intervention targets and to monitor their performance. PRT has been proven to be beneficial in individuals with ASD who are learning first words, as well as assist more advanced communicators in refining their language and social skills.
There are no specific requirements for who can implement PRT, because this intervention was developed initially for parents to be co-therapists. Since there is no official training or certification, training typically is provided through workshops and reading PRT manuals. There are personal attributes that a person who is implementing PRT must have in order for intervention to be effective. For an individual to be an effective co-therapist, he or she must show active involvement in the child and program, be aware of skill areas that are targeted, be willing to participate in trainings, and must be able to professionally receive feedback related to implementation strategies. Training typically requires about 25 to 30 hours of training with a single child. Trainings with other individuals that are important in the child's life, such as grandparents, teachers, or nannies, are also essential for a child's success. Parent training typically consists of following models provided by the clinician and direct feedback while the parent and child are engaged in activities of the child's daily schedule. It is recommended for the child with ASD to have 20 to 25 hours a week of intervention. Since delivery is consistent throughout the day, at the beginning of services, therapy will be more intensive, but will later fade as the child becomes more responsive to learning, self-monitoring, and initiations.
There are 7 techniques that are used in PRT that go into 2 categories: those related to presentation of opportunities to provide a response, and those related to the reinforcement that should be given to the child following his or her response. The clinician will present the stimulus or opportunity, and then the child will respond. The response can be target response, no response, incorrect response, or inappropriate response. All instructions given to the child should be concise and clearly related to the task, while the child is attending to the task or clinician. There should be a balance between the clinician and child controlling the environment. There should not be just the child or clinician choosing tasks or activities. However, the child should never have complete control of the task, and the child should be encouraged to make decisions. During activities, it is typically ideal to provide 3 opportunities per minute for the child to respond. Maintenance tasks should be used for the child to show that he or she had previously learned. There is no set time limit for maintenance tasks or acquisition tasks because interactions are based on the child. It is important for the clinician or parent to address the child's responsivity to multiple cues that require he or she to respond to 2 or more elements of the instruction. However, it is essential to adapt these tasks based on the developmental level of the child. Immediately following targeted behaviors, contingent reinforcements should be given. Responding to attempts are also encouraged even if it is not the exact target that is looked for. In result of the desired behavior, it is important for reinforcements to occur naturally. Social praise is also typically paired with reinforcements.
We will be demonstrating a simulation of Joe, a 4-year-old boy who has communication difficulties, specifically with expressive and receptive language. Joe's deficits in communication and interactions are characterized by his inability to utilize gestures or single words to communicate his basic wants and needs, or to connect with others, physical aggression towards others such as pulling hair, hitting, punching, or screaming, frequent tantrums when misunderstood, deficits in social emotional reciprocity, lack of conversational abilities such as joint attention, initiation, and maintenance, the inability to respond to simple directions, lack of nonverbal communicative behaviors, and deficits in developing, maintaining, and understanding relationships. Joe's restricted, repetitive patterns of behavior, interests, and activities are characterized by overselectivity to sensory stimuli, participation in primarily solitary play, the inability to adjust to daily routines, atypical sleeping habits, hypersensitivities to sensory stimuli, and seeking proprioceptive and tactile input. Due to Joe's persistent deficits in social communication and interactions, as well as restricted, repetitive patterns of behavior, interests, and activities, he has been given a diagnosis of autism spectrum disorder. Due to Joe's significant difficulties, he has been specified to level 3 support, which is requiring very substantial support. Due to his deficits in nonverbal and verbal communication skills, Joe does not frequently initiate social interactions with others and utilizes very few words to communicate.
The intervention is taking place in the Speech Hearing Learning Services Clinic, where Joe has visited approximately 3 times. Joe's communication partners during the interaction will be the clinician and his mother, who has been introduced to PRT and how to incorporate strategies learned in therapy at home. During this session, the clinician will be responsible for providing activities in which there will be 5, all of which may not be seen during our video clip. During the first 2 activities, the clinician will introduce the strategies for the session, begin to initiate interaction and responses from Joe, model the strategies for Joe's mother, and then transfer the last 3 activities to the mother. The role of the clinician is to provide constructive performance-based feedback and support to the parent during the activities, as well as provide Joe with positive reinforcement when he demonstrates the target behaviors. The role of the mother is to facilitate the strategies taught in therapy and take on the role of the clinician. For PRT to be successful, it is critical that the parent understand how to generalize the strategies targeted in therapy into the child's home environment. The intervention will be embedded among various child-friendly activities, including Play-Doh, Connect 4, Bingo, Bubbles, and Feed the Animals. We chose to utilize these materials during the intervention session as Joe's mother indicated these are some of his favorite items to play with at home. Our overall goal for Joe's intervention over a 6-month period is for him to independently use pivotal behaviors such as pointing, waving, and signing for no as functional communication acts. In 6 months' time, we would like to see Joe demonstrating these pivotal behaviors at least 20 times throughout a 60-minute session with the clinician or parent during play with no visual or verbal prompting. The following session will focus on teaching Joe's mother how to shape his hand into a pointing gesture so that the clinician feels comfortable that the mother understands how to reinforce this communicative behavior to express Joe's wants and needs at home. During this session, we want to see Joe point to a desired object to interact in his environment 5 out of 20 opportunities, or 25% of opportunities, during the 60-minute session with the clinician or parent during play with no more than 3 verbal or visual prompts per opportunity. And we want to see Roxy, Joe's mother, shape Joe's gesture into a point 15 out of 20 opportunities, or 75% of opportunities during the 60-minute session. Hi Roxy, how are you doing today?
Doing pretty good. Joe and I just got back from the park.
Oh, how did that go?
I think Joe had a pretty good time. Tell Miss Barb that you had a good time at the park.
Hi Joe, how are you doing, buddy?
Joe, are you going to tell Miss Barb hello?
The first strategy that Miss Barb will be working on with Joe is getting the child's attention and creating a learning opportunity. You can see Miss Barb doing this by getting within a close distance to Joe, leaning in to gain eye contact, looking expectantly, waiting, and offering him a choice in what toy to begin playing with.
Joe, let's put the blocks away so that we can begin with new games.
Thank you, Joe.
Joe, what toy do you want to play with? I have Play-Doh and Bubbles. I see you looking at Play-Doh, but remember, you have to show me which toy you want. Nice job trying to show me which toy you want, Joe, but let's try to point. Look, Joe, you're pointing at the Play-Doh. You made a great choice and you showed me what you want. Roxy, it is important to get within a close distance to Joe, lean into him to make eye contact, look expectantly, wait, and then offer him choices. I first reminded Joe that he needed to show me which toy that he wanted, then told him that we need to point so that he can make a choice. Then he knew I was going to shape his hand into a point. And then I had him point to the toy that he wanted. After Joe points, you should always reinforce that communication behavior with the desired object in order to build the understanding that when he wants something and when he points to it, he will receive it.
Okay, well, I already kind of do this at home, but I think that getting him to point, it'll really help people to understand what he wants and what he needs.
Yes, definitely. That point is going to make more meaningful communication for him.
That makes a lot more sense.
As you can see, Miss Barb reinforced Joe's choice contingently and immediately by giving him his Play-Doh. By working on shaping Joe's hand into a point, then providing him with the desired object, this helps to build an understanding of what this communicative behavior means. This is another PRT strategy.
Joe, do you want the big yellow roller or the small blue roller? Joe, I see you looking at this big yellow roller, but remember, you have to show me which roller you want. Nice job trying to point, Joe. Look, this is how we point. There's your big yellow roller. Roxy, it is important to provide Joe with various types of materials to reinforce his responses and choices when he's playing. And then, when he points to them, you're going to reinforce that choice by giving it to him.
Oh, okay. So we have a lot of different stencils and stuff for Play-Doh at home, so I could use 2 stencils or something, and he could choose one, or I could put it next to another toy, like Play-Doh and blocks, so you could choose
that's
the toy.
a perfect idea, Roxy. Okay. No,
The clinician is incorporating multiple cues by offering Joe various size colored dough rollers. Yet another PRT strategy.
Joe, are you all done with Play-Doh? All right, Joe, look at these new toys that I have. I have Connect 4 and Bubbles. Which one do you want to play with? Nice job trying to point, Joe.
Miss Barb is sharing control of the session with Joe by following his lead and offering him choices, which is another strategy for PRT.
Look, Joe, I'm blowing bubbles.
Like those, Joe?
If you want to turn, you have to point to the bubbles, Joe. Look, I'm pointing at the bubbles. Joe, that was a nice job trying to point. Come here. Do you want the bubbles? Let's point at the bubbles. Blow some bubbles, Joe. Let's try that again. Your bubble popped. Do you want more bubbles? Nice job pointing, Joe.
Good job, Joe.
Wow, Joe, look at those bubbles. Do you want some more? Up, Joe. Remember, we have to point if we want bubbles. Whoa, Joe. So, Roxy, even if Joe makes an attempt at a request to communicate with you, it's always critical to provide him with that reinforcement. So now I'm going to let you take over this part of the session and model for me the strategies that we have been over today.
Okay, I think I can do that.
All right, well, let's take a try at it.
During bubbles, the clinician was reinforcing the child's reasonable attempts by providing him with a turn. Parent involvement is the foundational component to PRT, as the clinician is responsible for coaching the parent and becoming the primary interventionist.
All right, Joe, do you want to play with the Connect 4 or do you want to play with the animals? I see you looking at the animals. Do you want to feed the animals? Show me. No, Joe. We don't grab. You have to tell me which one you want. Okay? Good job, Joe. Here you go. You can feed the animals now.
Roxy, that was good effort. You did a nice job at reinforcing Joe's attempt to point and letting him know that taking an item away is not the way to ask for it. But remember, we are working on having Joe point to indicate meaning behind the point.
Okay.
So it's important that we are shaping his gesture into the point before we give him his choice. Now let's try again and let Joe choose which animal that he wants to feed.
Okay, I'm sorry. I forgot about
that.
that.
That's okay.
Okay, Joe, now you need to show me which animal do you want to feed. No, son. We do not throw the box. You need to tell me which one, or show me which one you want to feed.
Woof!
You want to feed the dog?
Woof!
Okay, now let's feed the dog. You gotta show me that you want to feed the dog. That was a good try, Joe. Point to the dog. You want to feed the dog?
Woof!
Good
Woof!
job, Joe.
Now, Roxy, that was much better. When working on this at home, it's important to provide Joe with forced choice items, which is when you limit the choices between 2 or 3 items. Let's try this with the toy food. I want you to offer Joe a choice between 2 food items, for example, the bone or the carrot, and let him choose what to feed the dog.
Okay, Joe. Let's put the block down. We're gonna feed the dog. 'Cause remember, you asked for the dog.
Woof!
Yeah, the doggy does make a woof sound. Does the dog want a bone or does he want a carrot? Joe, we don't do that. You do not do that. I swear he always pushes my buttons.
That's all
Joe.
right. Let's just start over and try again.
Okay. Does the dog want the bone? That was a good try at pointing, Joe. All right, you ready? You want the bone? Do you want to feed the dog the bone?
Woof!
All right. Oh, good job, Joe.
Nice job, Joe. Roxy, you did a great job with reinforcing and hand shaping for Joe's pointing.
Be careful. Put that down.
It's important to remember that when interacting with the game, to provide as many opportunities as possible for Joe, so that this behavior can begin to carry over into other activities of daily life.
Okay.
All right, do you think that you could do that at home?
I think I could do this at home. I'm
All
pretty
right.
sure I could. I feel like I could do this with a lot of different activities.
Okay, so it's kind of like how we did it with the Feed the Animal game. We didn't just give Joe the toy after he pointed once. We then gave him multiple opportunities to try to generalize this skill. So we're going to do this by asking him to make a choice during the game, and then you gave him the animal, and then you gave him the food. Multiple opportunities can be implemented into any activity So it's just going to require some creativity and kind of thinking outside of the box.
Yeah. I think it might take some time.
Yeah, definitely. So we'll just try to do this at home as much as you can. And so I basically just want to sum up what the goal for this week was. So our goal was that we wanted Joe to understand that what pointing is. This means that eventually when Joe is asking for something that he wants, he'll be able to demonstrate that point to make meaningful communication.
Okay. Yeah, that makes a lot of sense. I think that'll really help him in the long run.
Do you think that you're comfortable implementing these strategies at home?
Yeah, I think I can start implementing them at home and trying my best.
All right, well, you're more than welcome to contact me, so anytime, all right?
Okay, thank you.
You're welcome. Thank you.
Did you have fun, Joe?
Joe, I can't wait till next time.
No, Joe.
Right, bye, Joe. Data is collected on both the parent and child during therapy sessions. This helps the interventionist to evaluate and monitor progress and adjust skills and goals. Videotapes are usually used to score motivational strategies because it can be difficult for both the parent and the skilled interventionist to do so during the session. Data collection will look very different based on the activity at hand. The clinician should motivate parents to collect data by reviewing it with them during weekly sessions and including them in this process. This process ensures the parents that they are an integral part of the therapy process. The clinician can also modify data sheets and use checklists so that data collection can be easier for parents to take. Data for both the parent and child can be collected throughout the week and can be discussed during weekly consultation sessions. Videotape probes can make data collection easier when collecting accurate data. However, this method is time-intensive and not always cost-effective for families. Representative probes during play can be collected in a natural setting, which can make data collection easier. A language probe data sheet can help to support troubleshooting when progress is not being shown with the child. This may give information on whether the right prompts and models are being provided for the child. At the conclusion of the session, the clinician explained to Roxy to keep working on modeling and shaping Joe's point throughout the week. At the next session, Roxy will bring in a 30-minute recording of Joe at home working on shaping his points, either with his mother or another family member. Prior to the start of the next session, the clinician and Roxy will watch the video together, and the clinician will teach Roxy how to keep data on Joe while at home. In regards to future treatment, after the gesture of pointing has been achieved, intervention will proceed to the next pivotal behaviors, including a greeting to wave hello and goodbye, and using the ASL sign no to indicate rejection.